Hello everybody, I am Dr. Sachin. Today's presentation is on temporal lobe epilepsies. These are the contents for the today's presentation. Case vignette, seizure definition and classification, temporal lobe anatomy, temporal lobe seizure, diagnosis and treatment. 24 years married male presented with the total duration of illness from the age of 11 years. Onset was abrupt, course multiple episodes. He presented with the history of heaviness overhead and had fear. There was history of lip smacking, head turning slowly to the left side. Patient was not aware of the surrounding and duration was for about 2 minutes. Occasionally, patient had episodes of stiffening of limbs, uprolling of eyes, frothing from mouth, tongue bite and urinary passage. Duration was for short duration and the episode it occurred at the night time too. Frequency once in 10 to 12 days, and once the episode occurred, it occurred for around 7 to 8 times per day. No depressive symptoms and biorhythm was normal. There was a history of febrile seizures and history of diabetes from last 4 years and no history of any substance use. Here we can see the video. This MRI report of the patient has been available here and has been shown in the picture. There we can see lesion in the left side of the temporal hemisphere. Now, what is seizure and epilepsy? As per International League Against Epilepsy, the definition of seizure is a transient occurrence of signs and or symptoms due to abnormal excessive or synchronous neuronal activity in the brain. And epilepsy means 2 or more unprovoked or reflex seizures lasting for more than 24 hours apart. That means the duration is the gap in between the two seizures is more than 24 hours apart. And second, a single unprovoked seizure or reflex seizure plus more than 60% of chance having another seizure over the next 10 years and an epilepsy syndrome. The seizure classification as per ILAE 2017, focal, generalized onset and unknown. In focal onset, aware and impaired awareness. Similarly, motor onset and non-motor onset, and focal to bilateral tonic and clonic seizure. What is the epidemiology of seizure? In globally, seizure is seen in 10%, and epilepsy prevalence is in around 1 to 2%, and the age wise a peak at 5 to 9 years and around 8 years. That is the bimodal age presentation. There is no significant differences when we look gender wise, and 50% of patients with epilepsy have partial epilepsy, and partial epilepsy is often of the temporal lobe origin. When we look into the data of Nepal, a community-based survey in Morang district was conducted in 2004. As per that data, the prevalence of epilepsy in Nepal is around 7.3 per 1000 population. Now moving towards the topic proper, temporal lobe epilepsy. Temporal lobe epilepsy was defined in 1985 by the International League Against Epilepsy, that is ILAE. It defined as a condition characterized by recurrent and unprovoked seizures originating from the medial or lateral temporal lobe. This is the anatomical picture of the temporal lobe. This first one is the figure showing the lateral side of the temporal lobe, and the second one is showing the temporal lobe from the inferior side. The temporal lobe is anterior to the occipital lobe and inferior to the frontal and parietal lobe and lateral to the sylvian fissure, that is also known as the lateral sulcus. These are the pictures showing the figure of temporal lobe from the lateral view, mid-sagittal, and from the medial portion. Now, the function of the lateral view. Lateral lobe, that is auditory processing, visual processing, language comprehension, and facial recognition. And the function of the medial side of the temporal lobe is the learning, memory, and emotion. And the structures included in the medial side of the temporal lobe are amygdala, hippocampus, oncus, dentate gyrus, and parahippocampal gyrus. What are the types of the temporal lobe epilepsy? One is according to the anatomical location. This is the mesial temporal lobe epilepsy. That means the seizure originating from the medial side of the temporal lobe. And another is the neocortical, which is also known as the lateral temporal lobe epilepsy. That means the seizure is originating from the lateral side of the lobe. There is another type called one focal aware seizure, second focal impaired awareness, and third one is the focal to bilateral tonic-clonic seizure. Previously, focal aware seizure was also known as simple partial. Likewise, focal impaired awareness was known as complex partial, and focal to bilateral tonic-clonic seizure was called secondarily generalized seizure. These are the etiological factors for the temporal lobe epilepsy. One is the genetic. Second one is structural lesion is in the brain. And in that, hippocampal sclerosis is the common one. Likewise, brain injury, including road traffic accident and birth injury, infections in the early life, febrile seizure, and the metabolic disturbances. What are the cardinal semiology of the temporal lobe epilepsy? In the prodromal phase, headache, personality change, irritability, anxiety, and restlessness. This prodromal phase, it lasts for second to minutes to several days. And in the aura phase, a patient may have fear, deja vu, jamais vu, hallucination like visual, auditory, gustatory, and olfactory hallucination. This could last for second to 1 to 2 minutes. And next is the altered consciousness and amnesia for the event. In that phase, there could be behavioral arrest and steering for about 30 seconds to 1 or 2 minutes. And patient may not be able to recall the event before the seizure onset, and there is also the post-ictal amnesia. And the most common automatism features are like opening and closing a door repeatedly, hand fumbling, hand picking and hand fidgeting, and chewing, lip smacking, and swallowing. The least common automatism are vocalization, ictal speech, affective behaviors, crying, and laughing behavior. What are the cardinal features of the mesial and the neocortical temporal lobe epilepsy? In mesial temporal lobe epilepsy, the features are typical auras like rising epigastric sensation, deja vu, and affective phenomenon. There is also unilateral motor signs, frequently ipsilateral contraction of face or mouth and head deviation, and bilateral motor phenomenon in the face or the axial muscle. Likewise, the features of the neocortical temporal lobe epilepsy are auditory, vestibular, and complex visual hallucination, aphasia, and focal sensory or motor phenomenon. There is another type of temporal lobe epilepsy known as ADLTE called autosomal dominant lateral temporal lobe epilepsy. This is a rare hereditary syndrome. Auditory hallucinations like humming, buzzing, and ringing are common in this type of temporal lobe epilepsy. This begins in the adolescence or early adulthood, and seizure may be precipitated by the specific sounds like the pieces of music, telephone ringing. Childhood onset temporal lobe epilepsy is another type of temporal lobe epilepsy. The features like eye opening, sitting up, or axial jerking could be present, and the feature somehow it resemble like the infantile spasm. So we can see what is actually the infantile spasm. We can see this in the After this, benign mesial temporal lobe epilepsy. This means mesial temporal lobe epilepsy with at least 24 hours of seizure freedom, either with or without anti-epileptic drugs. And what is the treatment? Treatment is with one anti-epileptic drug such as carbamazepine or oxcarbamazepine. Now the lateralizing semiological features. That means from the features we could lateralize whether the feature is from right or left hemisphere and whether the feature is from the medial or lateral side of the temporal lobe. In ipsilateral location, the features could be unilateral limb automatism, post-ictal nose wiping, and unilateral eye blink. That means according to this feature we can say whether this is in the ipsilateral side or in the contralateral side. Similarly, in the mesial temporal lobe epilepsy, the features are oral automatism, dacrocystic seizure, and gelastic seizure. And post-ictal cough and whistling in temporal lobe epilepsy. And in the non-dominant, that is the right side of the temporal lobe, the features are ictal spitting and drinking. Ictal emeticus and ictal urinary urge in case of the right-sided temporal lobe lesion, and piloerection in cases of left-sided temporal lobe lesion. In motor symptoms, if early non-force head turn or asymmetric clonic ending, then that could lateralize ipsilaterally. And if the head turn is late version and there is eye deviation, focal clonic jerking or fencing, tonic or dystonic limb posturing, unilateral ictal paresis, and post-ictal torts paresis. If these features are present, then the lesion is in the contralateral side. In cases of temporal dominant side, there could be features could be ictal speech arrest and post-ictal aphasia. And ictal speech perseveration, if there is ictal speech perseveration, then the lesion could be in the temporal lobe non-dominant side. How to diagnose this temporal lobe epilepsy? One is the clinical history, another is the MRI and EEG. So mainly we need to focus on the clinical history. What the features which I already described while in the table, that was in lateralizing semiological features. So as per it, we need to ask the history, and after that MRI of the brain. Here in these two pictures we can see there is some lesions in the left side of this temporal lobe in the mesial part. In this first picture we can see the hippocampal sclerosis, and in the second there is also differences in the intensity between this right and the left side of this medial side of the temporal lobe. And after this EEG we can see some spikes in this area, so we can also diagnose the temporal lobe epilepsy with the EEG. What are the treatment options? One is the anti-epileptic medication. Anti-epileptic medications like carbamazepine, oxcarbamazepine, levetiracetam, lamotrigine, and clobazam. Similarly, there are surgical options too, and following are the list of the surgical options available, and we can see here the picture of the hippocampal transaction. And another treatment option is the neurostimulation, vagus nerve stimulation, which has been already FDA approved in 1997. Another one is responsive neurostimulation, and the third one is the deep brain stimulation. This is still in waiting for the FDA approval. These are all the treatment options for temporal lobe epilepsies, and these are the references for the today's presentation. Thank you.